So welcome to this session. We're going to look at some of the outcomes from the urinary tract infection quaif and share the tips that practices put into place. Multidisciplinary management of UTI was one of several QI projects that clusters could choose from. I'd like to welcome Avril, who led on the audit of urinary prophylaxis. And Avril is Principal Pharmacist for Antimicrobials and Immunology at Cwmtaf Morgannwg University Health Board. She's a pharmacist prescriber in UTI, ENT, and skin infections for NHS 111. Avril, and in fact, both of us were committee members on the NICE Managing Common Infections committee. So thanks very much, Avril, for joining us. So just as a reminder, clusters had a choice of which UTI audits they chose, and most of the results that we had back were on the first audit on catheter for people with urinary catheters and the review of urinary prophylaxis. And most of the data that we had was from 2022. So looking at the catheter audit, so the advice is not to use dipstick testing to diagnose urinary tract infection in people with catheters. But the audits we had back, I mean, we only had results from a few practices, but each did identify episodes of dipstick testing. Of the actions that practices took place, and just to say it's all of us doing it, different professionals. So one of the key themes was to improve coding, to improve the identification of people who've got catheters. So it's much more easy when you look at records to see who's got an indwelling catheter. And the practices also often talked about meeting with the district nursing team so that we're all giving the same message. And also keeping up to date with the registers, liaising with the district nurses. Other suggestions included practice protocols and also a written protocol to be left at the patient's home for people who are housebound. So I'd like to move on to the prophylaxis audit. As I said, this was very much developed and piloted by Avril and the SWAP pharmacists. That's the pharmacist supporting Wales with antibiotics and primary care. First thing I knew about this audit was when this very impressive set of packs arrived on my desk, expertly split into the groups of people on urinary prophylaxis who needed to be reviewed, those who didn't need to have a review, and also indicating the urgency of that check. So I'd like to hand over to Avril, and just can you give us a bit of a feel of the background of the audit and some of the numbers? Thank you.
Yeah, so from my preliminary work, it was identified that from 3 GP practices, so 179 patients in that sample, that 22% had been on their prophylaxis for more than 5 years. So obviously the longer that we are exposed to antibiotics, the increased likelihood of resistance and resistant organisms that we carry in a poorer prognosis long term. So I felt that there was work to be done in this area in order to try and improve this. So the results from Cwmtaf with regards to these UTI prophylaxis reviews, I just want to highlight one cluster in particular, and that was Bridgend North cluster, who managed to achieve an 81% reduction in antibiotic prophylaxis from their reviewed patients, which led to a 50% locality reduction in antibiotic prophylaxis for the management of recurrent UTI overall. For Bridgend locality as a whole, 14 out of the 15 GP practices completed the audit, and they saw a 51.1% reduction within their reviewed cohort and a 39% locality reduction overall. For Rhondda and Taff Ely, 12 of the 17 GP practices there completed the audit, and they saw a very similar success rate in as far as 47.7% reduction was achieved within their reviewed cohort, which led to a 36% locality reduction overall. So taking both of these localities together, so 26 out of the 44 CUMTAF GP practices, there was 721, so 75% of antibiotic prophylaxis reviews were conducted. And 355 patients were stopped their antibiotic prophylaxis, which equates to a 37% reduction in antibiotic prophylaxis for recurrent UTI from these practices overall. If we put this into prescription numbers, it is estimated to be in the region of 4,615 fewer antibiotic prescriptions per year for CUMTAF Morgannwg Health Board based on 28-day prescribing. For another Welsh Health Board, they're within a cluster within that health board with a patient population of approximately 45,000 people from 7 GP practices. 57 patients were identified as being on antibiotic prophylaxis for recurrent UTI, which is thought to be about 0.1% of the practices population. 33 patients of this, so 58%, were prescribed antibiotic prophylaxis for more than 6 months duration. Of those on prophylaxis, 37, so 65%, were reviewed and stopped during the initial audit. For the re-audit, 20 patients were identified as being on antibiotic prophylaxis for recurrent UTI, and a further 4 of those were reviewed and stopped. It's important to note from the data from this health board that there was no indication as to the total number of reviews completed or whether the re-audit was or included the original cohort of patients, which is why I have separated them out as I have.
Thanks, Avril. That's impressive, and I know how hard you work to get that data back. So thank you for that. And it's impressive how many people who managed to stop prophylaxis really stayed off it at the 6-month review. From doing the switches and reading the practice feedback, it's clear that patient anxiety is a big issue when you're talking about stopping prophylaxis. Do you want to just talk us through a bit how you dealt with that in a consultation?
Yeah, so what I found was the bigger barrier to patients agreeing to try or stop their prophylaxis was a fear that they would go back to their pre-antibiotic state. So how they were when they were getting multiple bouts of UTIs within the year. So NICE defines recurrent UTI as 2 acute UTIs in 6 months or 3 within a year. So they were really apprehensive of going back to that because the antibiotic seemed to help to resolve things. So what I found was really beneficial for patients was to try to empower them to reduce their own risk. So there was a lot of discussion around things that they personally had control over that they could do to help keep them well. So that centred around behavioural interventions and hygiene measures. So things like wiping front to back, showering, post-coital things. I used the Target Treating Your Own Infection leaflet because I was really conscious that although I was conveying all this information to them, that not everyone was going to retain all of the information that I gave and with ambiguity. And did she really say that? So I found this leaflet to be particularly useful because there is a clear section on self-care, so options to help prevent a UTI, which reinforced all the things that they could do. It's also very important to mention and to keep at the forefront of our minds that hydration has such a crucial part to play in the management of recurrent urinary tract infections. So making sure that patients avoid dehydration and keep their system flushed by drinking adequate fluid throughout the day. Another option that they could try, this is not prescribable, but patients may want to buy D-mannose. There's significant and quite robust evidence that shows that D-mannose can help to reduce recurrent UTI infections. It's derived from cranberry, and it's believed to be the part of cranberry that actually has the effect on recurrent UTI. It has a NNT of 3, which is obviously, when you compare that to antibiotic prophylaxis, which is an NNT of 2, it is certainly something that's worth considering. And obviously with menopause as well, women, you may want to consider topical estrogens to help with vaginal atrophy, etc. So that's the empowering of patients to letting go of what they think has helped them. And often when there was still that reluctance, NICE recommends the timely access to antibiotics for an acute infection. I often wrote them a standby or a prescription that the patient could have for an acute course should they feel they needed it, just to help them or to relieve them from that fear that they would be left high and dry with the return of their symptoms. Interesting to note that very few patients actually cashed in this prescription. So in terms of empowering patients, also want to bring into focus the MHRA guidance around nitrofurantoin and the side effects of that. So particularly the risk of pulmonary fibrosis for both long and short-term use. So actually, if we can review these patients, that risk becomes mitigated to a degree. But obviously counselling and documentation of that counselling remains an important part of that consultation. And then in terms of empowering pharmacists, I think that this has been a really valuable piece of work where I felt that I was improving practice and improving outcomes for patients.
Thank you, Avril, that's great. And I think you also, just going back to that bit about giving patients the backup prescription or easy access to an antibiotic prescription if their symptoms recurred. I think you said you'd remind them to take a urine sample first, yeah?
Yes, I would give them a urine sample pot as well. Yeah, and my advice would be if you are about to take your acute course, please take a urine sample first, just so that it allows us to be more educated if there is treatment failure, and going forward we know what organism, so we can tailor treatment accordingly before the antibiotic messes up that sample.
Yeah, lovely, thank you, and confirms the cause of the symptoms as well. That's great, thank you. Okay, and some of the other things that I think we picked up through the audits. Oh yeah, sorry, this is just a reminder first of the things that practices did to try and support that recall of patients at 6 months to have their review. So making sure, which is the NICE recommendation, that the scripts are only authorised for a maximum of 6 months. There's the option to annotate prescriptions, reminding patients and staff that when the review is due, various different types of recall mechanisms, but also educating staff so that everyone understands what the stop dates are all about. Another practice said they used the resources for reassuring parents and shared them widely amongst the team. And across these projects, practices mentioned identifying a lead. So whether that's a nominated antimicrobial lead or a practitioner to review on the prophylaxis of people, particularly in care homes, and that could be any professional within the practice. So we picked up a few sort of do not do events. So people who are taking prophylaxis, if a patient gets an acute urinary tract infection, there's sometimes being prescribed the same antibiotic that they're taking for prophylaxis, and obviously that's unlikely to be to work because the bugs will have become resistant. And similarly, if an MSU comes back to the practice and there's resistance to the agent that the patient's taking for prophylaxis, then that treatment needs review. And a lot of practices did have an episode or more of these events. So in terms of what practices did, lots mentioned having clinical meetings and induction training for new prescribers or new clinicians coming into the practice. Improving coding, so it was much easier to recognise the people who were on prophylaxis. and considering regular audit and discussion of these events where they've been identified, and that's particularly with practices with the highest staff turnover. And we can empower patients as well, so that someone who's taking prophylaxis, we can remind them that if they do get breakthrough symptoms, it's likely they'll need a different antibiotic, or that they will need a different antibiotic to treat the acute symptoms. In terms of the MSU results, obviously remembering to check the MSU before prescribing for an acute infection, and checking the MSU before reauthorising urinary prophylaxis. If the MSU results comes into the practice, having a good system whereby that is checked against the antibiotic given, but also any prophylactic antibiotics, and making sure our clinicians involved in the review there. So that's the prophylaxis audit. I'll just quickly mention the other audits. One was making sure that people have a clinical indication documented. So this is aimed to improve patient safety through better communication and continuity of care. One practice mentioned that it highlighted high antibiotic use and particularly prophylaxis use, and they therefore planned a further audit and were going to offer that to their registrars. I think a lot of us have issues about samples being dropped at reception, and practices came up with different methods of dealing with that and how to gather the clinical information from the patient. Many use some templates, some use Flores, where practices are using those sorts of patient questionnaires. It was mentioned that it needs to be coded consistently when it comes back into the practice. So, in summary, I think the management of UTI has been improved through multidisciplinary team work. There's been substantial reductions in urinary antibiotic prophylaxis, and that's been maintained at 6 months. The need to give consistent messages for people with indwelling catheters is important and ongoing, and in fact that was retained in the NICE quality standards, which was updated in 2023. And just a reminder to our colleagues about those do not do's. This one quote from one of the practices was good, I thought. It said that the expectation of patients not wanting to stop their medications was not realised. Patients are often amenable to stopping once an explanation is given. Reduced prescribing and improved antimicrobial stewardship was a positive experience for the team, and will extend the process on regular reviews. So thank you very much for listening.